I am not a professional furniture mover, as you probably guess. The reason for shifting the furniture around is I just want to change the tone slightly, because this is a session where I want all of you contributing. I want you talking. I want to be hearing what you've got to say. And I'm going to be keeping Catherine very busy writing notes. Oh, have we got the zapper? Thank you. What do we got up there? Yeah, all right, good. The background to this is that we, for a long time, have always said to patients, you need to be treated at an expert centre. But we have never defined what an expert centre is. So what we need to do, and what we're planning to do, is to create a discussion document which we will take to CETOS and seek the agreement for a definition with the worldwide professional community. Now, there have been some very useful bits of work going on in this area over the last few years. I was lucky, I suppose you might say, to be involved in the English work on defining what expert centres were. And that work was published back in 2006, and it is still used today by the NHS in England as its guidance point for what a reference centre for sarcoma is. So I come with that background. But what it meant, going back all that time, was I've been looking at what other people have been doing. I'm aware of the English situation, and I've also been aware of the French situation, the creation of the NetSarc reference network in France, which, to the great credit of the people involved, has been very diligent about reporting how effective it has been. And Professor Jean-Yves Blaise deserves a lot of credit for that work, and I see Estelle there, and she has been very deeply involved in this work. In the UK, Scotland, it is a separate country, has its own approach. It's different from England, and what they have created is something that is genuinely an intelligent network. And I use that word intelligent in front of network very deliberately, because what they do, they have 5 centres. It's a relatively small country, 5 million people, but very scattered. If you look up on the northwest side in the Outer Hebrides, it can take a patient there a whole day to get to Glasgow, for example, which is where major hospitals are. So it's a very distributed little country with lots of transport difficulties because of mountains and water. But they have 5 centres where there is oncology, and 3 of those centres do surgery for sarcomas. The medical oncologists are all down in the southern part of the network. There are radiation oncologists in all 5 centres. So it's distributed, and you can begin to see how the pattern of patient referral works in a genuine network where even since 2004, they have been having weekly meetings, in those days just using the telephone. But today, of course, they use more recent technology. And it is effective. Retroperitoneal sarcomas are all treated in Glasgow, for example. The bone tumours tend to be focused on the 3 surgical centres in Aberdeen, Glasgow, and Edinburgh. And it works intelligently because the doctors talk to one another. Now, when I was sort of doing some early talking here, a couple of days ago, I was talking with Brandy from the Sarcoma Foundation of America, and she reminded me that they have actually done some work on this, defining what a specialist centre is in America. And they have these 10 points which they ask each centre to subscribe to. The centre self-reports, and it's expected to keep an eye on how it is evolving and changing. And those are the kind of things that are sought in that reference process. So it's very, very wide. And it's interesting that the team consisting of all specialties reflects very much what Sylvia and Sydney were saying earlier in the last session. So we have a challenge, and that's to produce a proposal which addresses the needs of a wide range of different national situations which need improving. But we need to do that without undermining the really valuable work that the Sarcoma Foundation has done in the USA, and without undermining European schemes like NetSarc, like the ones in England and Scotland, like what happens in the Netherlands, for example, or Scandinavia. So we need to reinforce good practice, and we need to try and find where things can improve, and we can help them improve. So, we're looking at the world, and you can enjoy looking at the world for needs of a picture, but I'll flip between it back to questions. Those of you that read the paper that Mickey kindly distributed last week will recognise that these are the questions that were in that original paper. What do patients need from their sarcoma doctors? Should the multidisciplinary team, as a term, be the focus for our advice to new patients, rather than talking about an expert centre or a reference centre? And I think there's quite a good arguments in favour as well as good arguments against a change. But who should be in that multidisciplinary team? Is it acceptable that different teams in different hospitals will treat different stages of sarcoma, for example? So you might have diagnosis in one centre which has got a lot of imaging capability, but surgery in another centre because there is a specialist surgeon who is competent to deal with the location of the tumour. And oncology in a different hospital, because where that surgeon works, there is no oncology. There is just very good surgery. These sort of things are what happens in reality, and we need to find ways of ensuring that we keep them and we recognise strengths and we find where the gaps are and where we can help. And there's a further 5 questions there, going into a depth about more specific issues. So, over to you. What do patients need from their sarcoma doctors? Is it incredibly simple, or is that complicated as a demand itself?
So what I'm going to say is probably a little bit controversial, but I think the fact that the word global now exists in the organizations. I noticed that the scenarios that you put forward were only from Northern Hemisphere high-income countries. If you look at the country I live in, we have less than 30 medical oncologists in the country to serve 64 million people. The majority of households live on less than $150 a month for a family of 5. And in order to get someone to move to a treatment center would cost them anything between $30 and $40 per treatment cycle. So you can see how by creating a center of excellence, you're actually creating a barrier for patients that find themselves in these low resource settings. those patients automatically think that they're not getting the right kind of treatment because of the way that their healthcare system is set up. And it creates a huge amount of stress on that patient, not only from the determinants of their health, but also on the practicalities of of accessing treatment. So I'm really, I mean, if you look at medical geneticists, we trained 8 last year in South Africa, genetic counselors, 8 last year, 8 left the country. So in these, and I might say that South Africa is the top healthcare system on the continent. So if you truly are a global network, these are things that you need to take into account. Because while a center or network sounds good, you have to think about the trickle down on what that means for the patient that's being diagnosed. Because that patient could feel like they're not getting the right treatment, where in fact, because of the way that the system is set up, they are. And that country has a way of dealing with these things and ways of doing that. But in a country where we have a shortage of, we only have the number of nurses of 40% of the required nursing staff in the country. This is a dream that'll never happen.
Thank you for that. You're echoing a paper which I did mention in the preparatory documents, which was one from Australia and Canada, from very respected sarcoma specialists, actually making exactly the same points that you were making there, but again from countries perhaps with a different wealth spectrum than South Africa itself represents. You've brought that particular aspect into it. I think that summarizes the dilemma. Robin, I see you poised.
Yeah, that's a fantastic point regarding resources. And I think even in quote-unquote wealthy countries, centralization can be challenging, and there should be sufficient resources in place in reference centers. Otherwise, the staff in the reference centers just become burnt out because of the volume of work. So I think that question regarding resource works in both directions, if that makes sense, Roger. That even if a country has a centralized system, that really does need to be well-resourced and well staffed.
Yeah, very, very, very important point.
I think that you brought up a very good point, and I think even within the United States, we do know the importance of sending patients to a sarcoma center, but it's not always feasible and not always realistic for patients to be able to afford to travel. However, you have to start sort of at the gold standard, right? And then work from there. So there kind of has to be a plan A, and then there's also, we have to work on a plan B. But I do think as we're developing these guidelines, we may not come to a consensus that every single one of us in the room can say this is it, but we support, they have elements of each, and maybe that's the goal, instead of saying we're all going to come up with one, because we know one can't fit every scenario in the room, but we have elements that we say these are very important, and then we have to figure out how to apply those to our country, in our individual situations, because insurance situations, healthcare systems, they're all very different across all of our different countries. So what are the elements that are important, that we think are the most important and can work in your country? And we develop that list, and maybe not in every one, because I know some things that work here won't work in the US. But then, and I agree wholeheartedly, and I've said this even in the US, we can't send every patient to a sarcoma center. I wish we could, but they're not going to get there. So then what happens to those patients who cannot? So I think maybe phase 2 of the discussion is then how do we solve that problem? But it is a valid point. But again, maybe the goal of this session can be what are the elements and how do we apply them to our own countries, rather than everybody thinking we have to fit into one mold. And maybe that's what you were planning to do anyway.
Thanks, Brandy. No, yeah, we're heading in the same direction. That I wouldn't disagree with anything you said there. Has anyone else got to the microphone at the moment? Ah, right, Marcus.
Maybe just to bring an example from the other part of the story is we now advocating for sarcoma centers, I think round about for 10, 12 years. And fortunately in Germany now we got into the process to get so-called certified sarcoma centers. That's fantastic, and this helped us a lot to deal with the whole topic and set up criteria and all these issues. But in the meantime, we have in Germany 21 sarcoma centers, and interestingly, there are some of these centers, they never show up before in sarcomas. That's a very interesting development, because now you have to become a sarcoma center, you need to be an oncological center, and we have round about 140 in Germany, oncological center, and out of these 140 you can become a sarcoma center. It's something, an extra module. Now, some of the hospitals think, oh, because there's a new module, might be interesting to get new patients and something like this, let's have a sarcoma center. And then they look who on the floor, who's running around, who could start the sarcoma center. So that means it's a little bit, I'm just over expressing the whole story, but this is also by getting these sarcoma centers and getting all this certification stuff in place, that's wonderful to fulfill all these criteria on paper, but this says nothing about quality, and it says nothing about the experience the patients are making. So this is the other part of the story. We are happy now to get these sarcoma centers step by step, but we now also need to understand how high is the bar to become a sarcoma center. So what is the number, or what is the bar? What are the qualifications to become a sarcoma center? But also what are quality indicators that show really that they are producing quality, and also that they are rated by the patient. So we also need something like patient satisfaction or patient experience to come out of these centers. So this is the other part of the spectrum. It's great to have sarcoma centers, but the question is, what is really the quality that's going on in this kind of sarcoma centers? Because as we all know, it always has to do with high committed and high experienced individuals like Robin and John and all Bernd and all these guys who are really passionate for sarcomas and really drive it forward. It has nothing to do with the hospital or with the structure around. When these guys normally are leaving the clinics, then the whole sarcoma centers will go down because they are losing their driving forces, they're driving their personalities. I think this is another spectrum of the whole issue, and we also need to raise the question, do we really need to treat every patient in a sarcoma center? That's also the question, because then many of the sarcoma centers will really get to their limitations, because as Robin just mentioned, there's a lot of pressure in the system, there's a lot of pressure also on the sarcoma centers. Are they really able to handle every patient? That's not possible in the reality.
It's intriguing, isn't it,
between each other.
that picture does actually pick up the point that was being made from South Africa, and the contrast that we're trying to deal with, and the range of that we're trying to deal with is so challenging. So we've got another voice to come over there as well in a minute as well.
Can we go first?
Yeah, Estelle.
I hear what you said about creating a gold standard and but how do we define what that gold standard is? Do we define it by the health system that the people find themselves in? In other words, do we build that health system for a health system that has universal health care at its core? Do we build the health system according to money and who has the most resources, or is that our thing? Or do we build it to the people that are, the number of people that are served? Because if you look in this room, 2.5 billion people that receive treatment or would have to access that health system sit in two continents. So between India and Africa, there are 2.5 million people. That's the most, so technically the most sarcoma people, population that you would have in the world. So what are we building that around? What are we building that best value or best example by, or gold standard by? Is it just because of resource setting? In other words, if you've got the most money, this is what it should look like? Or is it if you're treating the most or have access and creating a setting for the most people, or the healthcare system? I think that's very important, because it's easy to create a wish list of what's really, really good, and this would be the best treatment. But if it's not relevant to 2.5 billion people in the world, is that really worth the paper it's written on?
Well, that's why we have to then apply to our own country. Because I don't personally think, and this is really going to be controversial in this room, but I don't personally think we'll be able to come up with one that translates because of the different things that you raised right there. It is so different between countries. So that's why I think here's some ideal things that we would like the centers to have. Is it realistic for your country? Maybe not. Is it realistic for mine? Maybe not. But of that list, what is realistic for us? This is what we would like to see. Can we see it here? Maybe not. Can we get there in the future? Maybe. But I agree with you. You know, it's going to be very difficult, and I don't know that we will come out of this with this is the standard for across the globe. I personally don't think that's possible, but I personally do think we could come up with things that might be important to patients to have, and then how do we then translate to that to our countries? So I understand exactly what you're saying. I'm very much aligned in that.
Yeah. Thank you, Brandy. I personally agree with you. That first question up on the screen, the first one, is the most important question. And there is no other worldwide forum that can debate it. It's here, now, where we could debate what the answer to that question is. What do patients need from their sarcoma doctors? And everything else can spin from that. And it clearly has to be sensitive to national priorities, national resourcing. And, you know, let's be honest, in the European world, resourcing is a huge issue for our healthcare systems. So even if you look at Europe, there are going to be adaptations of any core standard, inverted commas, that we might have. Right, Estelle.
Yes. From the French perspective, of course, we are very lucky to have these expert centers, but we should also raise the issue of the evaluation of these expert centers, because, as Marcus previously said, this is firstly a question of certification. It's important for some centers to get their certification. Some have this certification for good reasons, because they have all the skills, but what happens when these people are moving? And clearly we have the example in France, in some certified expert centers where we know there is no more surgical expertise. So this is an issue for the patients of this area, because they expect to have a high quality surgery regarding sarcoma, but in the reality we don't know, we know that it does not exist anymore. So and it is very difficult. We've already had this discussion with the experts many times, what to do in case this expertise is flying away, because these centers remain certified without any more sarcoma expertise. And it is really difficult to withdraw this certification, because of course there are money issues behind that. And so it comes to a very difficult situation, because in the reality we don't know how many expert centers remain. Sometimes you have one oncologist remaining in the center, but it is enough to keep this certification when you know that there is no more surgery. Thank you.
I agree with you. I think as we've discussed before, I personally am totally against a certification system which relies on external certification, because the first thing you have to address when you set it up is how do you withdraw a certificate of competence, of expertise, when it needs to be withdrawn. And it's always a challenge. Robin, you want to come back?
Yeah, just quickly, I agree with everything that's been said. And just to follow on from Marcus's comments, I think the sort of mentorship and training younger doctors is really, really important. And that sort of transition almost of knowledge and expertise is really critical to try and keep hold of. And the second thing is the value of networks, particularly when geography is a challenge, as in the United States. I think building up relationships with community oncologists is really, really important, and that can work well. That sort of free flow of communication between doctors is essential. And I was telling John, I still have community oncologists from the US phoning me up sometimes saying, well, what do I do? And I keep telling them I'm no longer in the US, I'm in the UK. But they, well, no, just help out. And so I think that communication is really, really important.
Oh, John.
Yeah, I would just like to add to that. These are all great comments, and just share some of my experiences over the last few years in the US and globally. And so in the US, during the pandemic, the Medicare and the government decided to let us see patients from any state in the US. In other words, my Florida medical license was valid across the whole US. Before that, I could only do telehealth with patients who lived in Florida. I couldn't do telehealth in New York, California, Texas, because I didn't have that license. And during the pandemic, it made it substantially easier for me to provide a consult, one-time consult often, by Zoom to a patient in Alaska or California. I was seeing a lot more patients all over the US. And we have digital pathology. We transfer CAT scans, MRIs, PET scans electronically. It worked really, really well. And then the intelligence of the US government decided to stop that. And so in the US, I can only see patients in Florida unless I get a medical license in all 50 states and the territories. Some of my colleagues have multiple licenses and do that, but I can't do a one-time Zoom visit. I'm not allowed to do it, even if they want to pay cash. And a one-time consult with us, you know, I understand it's a lot of money in many parts of the world, but it's about $300 for me to do a 1-hour consult with somebody as a new patient. In the context of prescribing ripretinib, which is $21,000, you know, a month or something like that. And I gladly do it. And they get the pathology review by Andrew Rosenberg or some other sarcoma expert. And they, you know, that's the foundation that we base all of the care on. And they get the imaging review, and I present at multidisciplinary conference. And we could do that easily throughout the US, and for patients particularly who couldn't physically travel or didn't have the wherewithal to travel to a sarcoma center. It worked really well. And then, as Robin was saying, I could follow up with the medical oncologist or the surgeon with a phone call, with an email, through WhatsApp, and make sure everybody's on the same page. A couple of times we've had several times we've had the treating physician on the Zoom visit also. And so we're all talking about it together, and it really, really worked well. Sometimes we would invite them to our multidisciplinary Zoom tumor board, and it worked really well. And then we also started seeing a lot of patients globally because people got used to Zoom, and they got used to electronically transferring CAT scans, MRIs, et cetera, and digital pathology during the pandemic. So we see a lot more international patients than we used to. because we can do it by Zoom now, and none of the Medicare licensing applies if the patient's outside the US. So it's a lot easier for me to see a patient who lives in India or Australia than it is somewhere in the United States. And like say they live in Manhattan. That's a lot more complicated than Australia somehow. But I think the harness, you know, we all recognize sarcoma centers. We all recognize that patients seen at sarcoma centers have better outcomes. And harnessing some of these electronic methods of telehealth, et cetera, you know, could be a way for sarcoma centers to impact patients who can't physically travel. And particularly in the US, I would think that there would be some grassroots, or could be some grassroots involvement that I would support that would allow exceptions to this medical licensing rule for rare diseases, particularly in rural populations. And so I would think that there could be some traction there. Thank you.
Thank you, John. Good one.
Maybe true.
And thank you for bringing this issue of the technology into it, because I was going to come round to it and say, we're seeing, and John's just beautifully illustrated it, how the world of technology is giving us new tools to communicate. And we're not yet considering them within the context of specialist expert treatment. It's where I use that term, intelligent networking. And an intelligent network, in my view, would be something where there is perhaps a physical underpinning for it, with individual experts in specific locations, but the intelligent network allows them to work easily together, and it allows them to draw in other expertise as and when they see it is necessary. So that, for example, you could be running a multidisciplinary tumor board meeting in your country, and by invitation you've brought in John Trent from Florida because he's got some specific knowledge which you know about because he's run clinical trials and he's published and so on, and you want his view on a particular case. That to me is intelligent networking. Similarly, you have the tumor board has a patient with a very difficult sarcoma, say one located in the neck, where there are multiple major organs which surgery can impact on. And the surgery will be life-changing for the patient, whatever happens, but you want the real expertise of someone who specializes in head and neck surgery to be part of the discussion about this patient, and possibly to be the person who operates on this patient. But they would operate in their own hospital, in their own center, which is not part of the stated multidisciplinary network that you've got. Now that is intelligent networking. And I know that sort of thing goes on, and we need to find a way of reflecting it in whatever it is that we put forward. Sorry, there's a particular set of opinion, Marcus.
Maybe two aspects to this. One is we as SPAEN, also in our German organization, we receive maybe 2-3 requests by email per week from patients from all over the world, mainly in our situation from Eastern Europe, who are requesting a second opinion, maybe in Berlin or in Milan or wherever. The problem is not to send the patient maybe to a second opinion. This could be feasible, and maybe also the patients are able to pay for this. The main issue is what to do with the second opinion if the patients are coming back into their countries, and if they don't have surgeons, if they don't have the specialists in place. And this is the same with these digitalization. You can do wonderful tumor boards around the world by exchanging knowledge. The question is, what are the practical issues if you are back in your country and disciplines are not available, knowledge is not available, drugs are not available. These are the issues we are talking about. And that's on one side, we need to assist and we need to collaborate and we need to network, but we also need to force and push the power that we get minimum standards in the countries. And this means not that we, for example, just take a country like Romania, that we need maybe 5, 6, 7 centers in Romania. Could be helpful to have one center in Romania. Maybe the experts are living in different cities in Romania. That's not the issue, but they work as a network together and they build up something like a sarcoma expertise in Romania. And specifically because Romania is one of the examples, they are working close with Vienna. So our Austrian colleagues in the moment, the doctors, the experts, they help within Romania to create something. But this is the reality. So on one side, it's good to have this international networking and digitalization and second opinion and all these issues, but we need the resources, minimum resources in the different countries, because otherwise it will be really challenging.
I just wanted to add to that, Marcus. I agree with you 100%, 100%. I would just add that as sarcoma oncologists, we have an obligation to be practical. Like you said, we've got to be practical with the situation, and we've got to sometimes be creative. And we also have to communicate with the oncologists because they know what resources they have. And we cannot, and I mean, it's really disingenuous, it would be disingenuous for us to recommend a resource that they don't have. That would be unfair to the patient and really unfair to their healthcare system. But I agree at the same time that helping healthcare systems globally be able to better manage sarcoma patients is critical.
I think it comes to that adage of who's the better doctor, the person that does a trachea in a sterile surgical unit or a guy that does it on a restaurant floor with a pen and some vodka. One thing that does interest me and Marcus on what you said is that kind of engagement is exciting for me as a patient advocate because it tells me what my patients are needing and what they're missing out on. And it tells me what I should be advocating for in my healthcare system. So I'm not as scared of that as it, because I understand that the doctors, as you said, would do what needed to be done and within the constraints of that. But for me, as a patient advocate, that tells me where my patients are missing out. And often, you know, in my organization, we advocate on a doctor's treatment plan specifically for that patient. And I think that, you know, that is for me maybe a guide to use on what I'm asking specifically for access in my country, to look at guidelines and things that are being allowed into the country or that. So I'm not so scared of that in resource setting because of the resource setting, understanding that the doctors would eventually find something that the resource was able to sustain. But it does give me an inkling of what our patients are missing out on.
I want to just put in some thoughts which came from people that are not here. Ornella Gonzato said to me, we've got to focus on patient-centered care, not doctor-centered care. I think that's a rather interesting comment in this context, and it picks up on the point you've just made. Care must be of good quality and obviously must be safe. I think we take that for granted. But it means we've got to promote expertise, which of course we do in the context of an expert centre, but we're now also talking about the way that we're describing distributed multidisciplinary teams. We're talking about individual expertise, not centre expertise, as part of the case. And Gerard van Oudtmeysen, who sadly couldn't be here at all, with a background in technology, I have to say, raised this term, the intelligent network, and also pointed to the growing, rapidly growing use of artificial intelligence in the medical field, and just raised the question of what place is that going to have in the future of the provision of services to sarcomas. But he also made the point that the sarcoma expert is a part of a community of experts, as well as the community of sarcoma more generally, which you might say we represent. And we need to foster that community of experts as well, through individual centres, through their collaborative work in research, for example, and through the way they meet and share their knowledge, both formally and informally. So just a few extra additional things to think about there in the context of what we're talking about. I don't at the moment see another hand up. Have you distributed a mic, Mickey? We can't have run out of opinions, surely.
Yeah, I think from a small country perspective, the concept of a network is more realistic. I mean, you'll never have the volume of patients for the ultra rare. You can build expertise on the more common sarcomas, and you might get a great expert who wants to come and live here. But then if they move, you talked about building the junior doctors, and I think having that network across borders, whether that's at an EU level or an inter-country level, is for us makes more sense. The challenge we have with the network is scanning, and it's the having the same technology and the ability. So we would have 3 or 4 hospitals in this country. They're not all in the same system. So when you're meeting with, whether it's a radiation oncologist or a medical oncologist, it's getting the right person to look at the scans rather than just a random radiologist who doesn't know sarcoma. But I think there's great opportunities in this discussion, so thank you.
Yeah, I totally agree. And I think one of the things that always sort of strikes me is the communication between people and between doctors, which is really, really essential. I know some fantastic oncologists in South Africa that are really, really good doctors. And, sometimes I link in with them when they've got very challenging situations, and I think that communication is really, really essential. And I don't know how to sort of, just emphasize that enough, that, free communication and discussion is really, really important, because very often there isn't a right or wrong answer, and it's a case of sort of weighing things up with an individual patient, but also within these sort of group of doctors treating a particular patient. So.
Could you use the mic? Sorry. No, I can't hear you, you see.
I just want to know, after a medical conference, do you go off into your countries and or Irish? No, I'm saying the doctors. The Irish doctors don't attend these conferences. Exactly. So what happens is, like, John Trent will go to another city in Florida and maybe give a recap of ASCO. And so that's a way for the doctors to, like, learn more about what the findings are. I just wanted to, like...
At the University of Washington, I used to go to Alaska. I always told them I should go to Hawaii more often to give updates. But Montana, Alaska, Idaho, we would go out and give updates, and do that in the UK as well. So it's a good thing to do. Yeah.
If that country is represented, yes. But for small countries, if there isn't a formal network, it might be just Chinese whisper.
I deliberately chose that Scottish example as a small country with a very effective network, because I think it's a model which small countries should look at. They may not choose to do exactly the same. They may choose to do it their own way. I'd expect that. But it provides a good baseline learning experience for them to work with. Bernd?
Yeah, I just wanted for the networking. I mean, that's actually the idea of Eurocan as well. So our European reference network, of course, which is dedicated to Europe only. So the idea is not to transfer the patient. The idea is to transfer the knowledge from one center to the other. I mean, you can debate about that if that works or not, but at least that's the idea.
Can I ask a question to our medical colleagues? Just as a vision. We are in Germany currently as patient advocates involved in building up a part-time training course for precision oncology. And this is a 2.5 years training course for doctors. That's a fantastic development. This is new, and we are all very fascinated about this, to build up this kind of training course to really train people on precision oncology. And a lot of people are involved in this with a high motivation, including the patients. The question is it feasible to come up maybe with a training course for sarcoma teams? Let's call them teams, not centers, teams. And to come up with an idea, we just heard about digitalization, Zoom meetings. You can do easily these kind of trainings across the world via online. So the question is it feasible to create something like this, where we create teams in different countries? Maybe there are interested people in South Africa or in different other areas, where you train the multidisciplinary team, but also where you train the different indications. So you have the pathologists, you have the surgeons, you have the oncologists. So you do training for the individual groups, for the disciplines, but you also do training for the whole sarcoma team. Is this feasible, maybe to do this together with EOTC soft tissue and bone sarcoma group, with CTES, to set up maybe a 1-year part-time training course for such people?
I think that's an idea we need to carry forward, Marcus. I think that there's some strength in that. Now, we're running close to we're probably running over time now, but my timekeeper is not being too brutal with me. Not yet, at any rate. I just want to focus quickly on that last questionnaire, the one at the bottom. And if we do develop a new policy, and we ideally do that working with our professional colleagues, so that John and Robin and Bernd, their community is working alongside us. We're heading in the same direction. What does success look like? How will we determine what success means?
So we've had a lot of discussions on how do we fit healthcare systems and that together, but maybe we should go back to that first question on what does the patient want? And we sit and we start that and put that down at, in its most primitive, basic. A patient wants to know what's wrong with them and how we're going to fix it. That's any patient, if you had to take it. There's a lot of other stuff that obviously I'm simplifying. But maybe we can take those wants and those needs of the patient and then ask those healthcare systems how are they going to accommodate those wants and needs, so that we're making those wants and needs known to the healthcare system, and then a way of checking are those wants and needs being answered? Because at the end of the day, that's the best journey for the patient, is if their wants and needs are being answered. It doesn't matter how the healthcare system does that. That's up for the healthcare system and the doctors to develop a mechanism of that. So I don't think maybe we should be defining what the mechanisms are, but more so putting out there what the patients want and what the patients needs, and then a way of not certifying, but making sure, is saying, well, is this happening in your setting? Is this, what is this being done? And that's how your accreditation works, is are you answering the patient's wants and needs with whatever system you've set up around them?
I think that's lovely. Focus on the outcomes, not the process, is what you're saying, which is, I think, really, really powerful. Anyone else want to contribute a final thought.
I'm just like to talk about the patient journey coming into Sarcoma Centers, because you mentioned about patient-centric care. Maybe we should look at how do we gain information on how the patient gets to the Sarcoma Center and what their experiences are, be it questionnaires, discussions, platforms, registries. Those are the things that we can think of to glean that information so that then we can provide the care around it, as opposed to setting up systems to cater to them. We also can, at the other end, look at what is the patient going through in terms through the healthcare system, through their journeys and stuff, because sometimes they do get misdiagnosed and they take a non-linear route to get to their care. So that's another angle to look at.
Yes, an interesting one. I've been treated in 7 different hospitals. So yes, you're right. I thought there was someone else who... Oh, sorry, Bernd at the back.
I just wanted to highlight maybe at the end that this is a topic, as most of you probably know, is also very highly discussed at the CETOS board at the moment, or in the CETOS community. I mean, so outreach is one of our committees, which I'm actually chairing there, and so that even led to something we put in place this year, which is a travel grant, a global equity travel grant for those who are from underrepresented countries, submit an abstract and they will be covered, so all their expensive flight, hotel, and so on, registration. And if you look at the CETOS website, the motto of this year's conference, which is, by the way, also in Dublin, is Global Outreach, Global Impact. So, yeah, just wanted to highlight that. So we want to give that back to CETOS again, and as we have a formal collaboration since last year, and would be good to put that together.
I think that's a fantastic point, Bernd, and following on from Marcus's comment, I think trying to do something on an international level in terms of education and training is really, really important, because my concern in the UK is if somebody, as you say, leaves, then there's a really rocky sort of transition period very often, and that sort of succession planning, with the help of organisations like CETOS and ESMO, and with the help of everybody in this room, patient groups, is really, really important, I think. And I think it's really important that CETOS, with additional funding, uses that funding to sort of help carry on expertise in individual centres. I think in terms of the last points on the slide, just quickly, I think that's clearly sort of multifactorial, and a lot of things go into that. But I think patient experience, outcome, access to clinical trials and research, quality of life, all of those things are really, really important for measuring success.
Could you pass the mic behind you, Robin, to Vandana? Thank you.
According to me, success looks like equality in health equity. That is the most important thing. And even here, when we are discussing anything, it's only related to Europe and America. But we forget the other countries which are underrepresented over here, and we don't even know about their issues and problems. So if you want to really bring, like success into the entire scheme, we need to discuss with the professional colleagues in the other countries, because there are people who are working there, and understand their challenges, and then work according to what the need can be. And work accordingly, like how to give the best to the others also. We talk about sarcoma centers. We don't even have hospitals which are treating sarcomas. So where will we get the sarcoma centers to be there? So what can be the, what can be the mean method of getting into it? Like what can be the normal about it? How can we get the best for all the patients across the world, and not related to only Europe and America?
Absolutely right. Brandy, I'll give you the last word, and then I'll just do a quick sum up.
That's great, because it's a circle back. I'm circling back to something that our South African colleague had mentioned is, and let me say this, our sarcoma team, our doctors, our network in the United States are fantastic. They work together, they communicate, they're great. But we're patient advocacy organizations, and I think our medical colleagues should factor into this at some point, but it goes back to Lauren says and something that I said earlier about the gold standard is what do patients need? What do the patients want? We can make a list of those things and then figure out, can that happen in my country? And if it can't now, as she said, how do we get there? Let them figure that out. And then we can bring in our medical colleagues, but we are here for the patients. What do the patients need? What the blue sky would we want them to have? And maybe we can't implement that everywhere right now. We understand that, but that's what we're working toward. But so yes, medical colleagues come into this and the networking, and I'm all with John in the United States about telehealth. I think I've talked to some of you about that already in the United States. But that's what we're here for. So the patient, what is that very first question that you asked is really the only question. What do patients need? What do we want patients to have when they're getting treated? What is that patient journey from misdiagnosis, and how do you even get information all the way through? What does that look like? I think that's where we begin, and I think, to me, that's the gold standard, and how we do something from there, we can figure that out.
Thank you. That's a very nice summary. I'm not sure that anyone's going to disagree substantially with that. Let's just tell you how we're going to take this forward. We'll produce a little summary document from this discussion, and we will send it to everyone. We've got all your emails. We'll send it to everyone. Comment back, please. Send comments back. Don't hesitate. It can be one line. It can be a whole page. I don't mind. We'll read them all carefully and do what we can to assimilate the points that you make. And please, an answer from South Africa. We're really important. You've made some really, really valuable contributions into this discussion, because it's the first-hand experience that you have that I don't have, but I'm now in contact. So please, I want to keep that sort of input coming. We aim to put an abstract to CETOS so that, assuming they accept it, we can do a presentation at the CETOS meeting here in Dublin in November, getting this issue on the table with our professional colleagues. Bernd, you're going to say something on that?
Just in this respect, I want to highlight there will be a special session at CETOS about this topic, improving sarcoma care globally, including access, equity, advocacy as well. So besides this project, if there are any other interesting projects from your countries and so on, I really encourage you, submit your abstract. We will have a close look at that, and it might be a chance to present there. It will be a 1-hour session at the very beginning of the whole conference, just after the introduction.
Good, thank you. So, if you really feel you can contribute at CETOS to this debate, put your own abstract in. Let's have a look at it and we can comment on it and help you. But, if you want to tell your story in ways that can impact on the global community, please come forward and try and do it. How we move forward after CETOS is going to be very much down to the kind of response we get from that session that Bernd mentioned. But we're not going to drop this. We're going to take it forward. And I think having, some of you very alongside some of these issues already, hopefully now all of you are more alongside than you have been, and we can continue the discussion in different ways over the coming months. So thank you for your input today. Please stay connected on this topic. Respond to the email. Thank you. Coffee break. Sorry. As if I didn't feel I needed it.